Greetings. I'm Dr. Karl Nath, the editor-in-chief of Mayo Clinic Proceedings, and I am pleased to welcome you to the multimedia summary for the journal's May 2022 issue. There are 3 articles that have been selected as our editor's choice or highlights this month. The editor's choice this month is entitled Mental Stress and Its Effects on Vascular Health, and it is authored by Dr. Jaskanwal Sarah and colleagues from Mayo Clinic in Rochester, Minnesota. The interplay between the psyche and the soma in general, and the extent to which debilitation and disease in one adversely affect the welfare of the other, in particular, is of long-standing and mounting interest. Sarah et al. Discussed this dyad from the perspective of mental stress as a determinant of vascular disease. The authors summarize cardiovascular outcomes observed in prospective cohort studies published in the literature from 1990 onwards, in which mental stressors were imposed. In this analysis, some studies inferred that a greater sensitivity to or impact from mental stress may be a harbinger for worse cardiovascular outcomes. In assessing these studies, Sarah et al. Emphasize the distinction between acute and chronic stress, as the former may induce acute hemodynamic, inflammatory, and other immediate responses, whereas the latter may lead to the steady accretion of pathologic changes that ultimately culminate in cardiovascular disease. How the latter occurs is uncertain, but a critical proximate event appears to be injury to the vasculature for at least 2 reasons. First, based on a summary of cross-sectional studies that assess peripheral vascular reactivity, it may be inferred that these responses are affected by mental health, and that such vascular responses may be abnormal, in particular, in individuals with cardiovascular risk factors or disease. Second, a critical pathogenetic process early in the course of virtually all cardiovascular diseases is endothelial dysfunction. This abnormality impairs vasorelaxant responses and leads to a pro-inflammatory, pro-adhesive, and prothrombotic endothelial phenotype. Each of these components of endothelial dysfunction is potentially vasculopathic. What then are the processes that link endothelial dysfunction back to mental stress? This efferent arc, as envisioned by the authors, is as follows. Mental stress activates the cerebral cortex, the limbic system and its constituent amygdala, and the hypothalamic pituitary adrenal axis. This leads to increased production of catecholamines and corticosteroids, activation of the renin-angiotensin-aldosterone axis, abnormal lipid metabolism, increased sympathetic output, and decreased parasympathetic activity. Such effectors, along with systemic inflammation and immune responses, all converge onto the vasculature and through a plethora of pathways incur endothelial dysfunction. Repetitive targeting of the endothelium and the vasculature by these processes occasioned by intermittent mental stress in time provoke overt disease in the central and peripheral vasculature. The authors conclude by emphasizing the need for studies on mental stress that differentiate between acute and chronic stress, and for studies applicable and generalizable to the real-world setting of cardiovascular disease, the latter commonly multifactorial in its origins. The authors also conclude by discussing therapeutic strategies that target mental stress and those that target endothelial dysfunction. This timely review is important for several reasons. First, it draws attention to a poorly recognized but likely driver for cardiovascular disease, and one that may be targeted by appropriate strategies. Second, it underscores that there is more to the accounting of cardiovascular disease than the current complement of traditional risk factors. Indeed, in this issue of Mayo Clinic Proceedings, these authors also extend their previous studies and demonstrate the fascinating and unexpected association of a non-invasive voice biomarker with incident coronary artery disease and its prognosis. A third important implication of this review relates to our responses to mental stress. While life stressors are clearly unavoidable, our response to them may be tractable, at least in part. Such tractability and our success in consistently allaying the impact of attendant mental stress may influence our cumulative and long-term risks for cardiovascular disease. The first highlight is an original article entitled Association of Changes in Physical Activity and Adiposity with Mortality and Incidence of Cardiovascular Disease, Longitudinal Findings from the UK Biobank. It is authored by Dr. Matthew Amadi from the University of Sydney, New South Wales in Australia, and colleagues from the University of Glasgow in the United Kingdom. There is a general consensus regarding the salutary effects of adequate amounts of physical activity and limited adiposity. Amadi et al. Used data from the UK Biobank to assess whether a relatively delayed increase in physical activity or delayed decrease in body mass index and adiposity still exerts beneficial effects on all-cause mortality and incident cardiovascular disease. Physical activity, BMI, and body fat were assessed at baseline and after an average follow-up of 7 years. Physical activity was categorized either as inactive, insufficient, or sufficient. The latter two categories based on a cutoff of 150 minutes of moderate to vigorous intensity physical activity per week. Physical activity was also classified as decreased, stable, or increased as judged from baseline values. BMI and adiposity were categorized as decreased, stable, or increased at follow-up. The essential findings were that individuals who increased their physical activity to the sufficient category at follow-up exhibited all-cause mortality and incident cardiovascular disease that were not only lower as compared with the stable insufficient group, but indeed matched these indices in the category with sufficient physical activity at both time points. These findings were observed across the three categories of BMI and adiposity. While the associations between adiposity per se and these outcomes were less consistent as that exhibited by physical activity, incident cardiovascular disease in obese and overweight individuals who reduced their BMI category was similar to what was observed in the group with an acceptable BMI at both time points. In analyses that combine changes in physical activity and adiposity, the group with decreasing adiposity and increasing physical activity exhibited reduced all-cause mortality and incident cardiovascular disease as compared with the group with stable physical activity and adiposity. These findings indicate that increasing physical activity and decreasing adiposity confer salutary effects even when achieved at a relatively later stage in life. Oscar Wilde famously wrote that every saint has a past and every sinner has a future, a statement that emphasizes, at least in one interpretation, the ever available opportunity for and the benefits of wise and welcome change. Increasing physical activity and decreasing adiposity are two wise and welcome lifestyle changes that are better late than never. The second highlight is an original article that examines insufficient psychiatry services in the acute care setting in the United States, and it is entitled Specialty Psychiatric Services in U.S. Emergency Departments and General Hospitals, Results from a Nationwide Survey. It is authored by Dr. Ashley Ellison from Novant Health in Winston-Salem, North Carolina, and Tulane University School of Medicine in New Orleans, Louisiana, and colleagues from other institutions in the United States and the Netherlands. As outlined by the American College of Emergency Physicians in their 2014 analysis entitled Care of the Psychiatric Patient in the Emergency Department, salient relevant issues include an increasing number of patients with psychiatric illness, the declining number of dedicated hospital beds for psychiatric patients, the directing of such care to the outpatient setting, which is limited in its capacity and resources for such care, and in turn, the growing numbers of patients seeking acute psychiatric care in emergency departments, the latter challenged in providing such care by their inherent organizational structure, delays, and various regulatory requirements. The present findings of Ellison et al. Underscore the deficiency of psychiatric services in the emergency department and in the inpatient setting. In their telephone survey of some 2,400 US hospitals, 54% of hospitals did not provide psychiatrists for consultation in the emergency department or in inpatient services. And for those patients with psychiatric issues requiring hospital admission, some 60% of hospitals transfer these patients to another hospital, with approximately half of these patients admitted to a medical inpatient service. The lack of availability of psychiatrists for consultation was higher in rural hospitals, in hospitals with fewer beds, and in for-profit and government-owned hospitals. In their discussion, Ellison et al. Highlight, among other considerations, reimbursement and administrative issues that may underpin their findings, the adverse effects of such deficiency of psychiatric services, and the extent to which telepsychiatry may mitigate such deficiencies. The present findings of Ellison et al. And the broader unsettling landscape regarding the provision of acute psychiatric care in the United States are sobering. Surely the US healthcare system can and should do so much more for individuals afflicted with the tragedy of mental illness with all its attendant tribulations and hardships. You can access these highlights and editor's choice articles free of charge during the entire month of May. Please visit our Mayo Clinic Proceedings website at www.mayoclinicproceedings.org, where you'll find links to our social media by clicking the buttons at the top of the home page and at the bottom of any page to follow us on Facebook, Twitter, and YouTube. On our YouTube channel, you'll find full-length author interviews called Insights, 60 seconds video article synopses, and our Mayo Clinic Proceedings issue summary and author insight podcast recordings, which are available from our website on the homepage as well as through iTunes. You will also find our online-only features and many news stories posted in the News from the Editor carousel on our website homepage that are based on articles published in Mayo Clinic Proceedings. And finally, you will see other free content as well as articles published online in press. As always, we greatly thank you for your interest in and your support of Mayo Clinic Proceedings. We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us Our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.